My name is Dr. Lenore Powell, and this presentation will focus on the interpretation of the NutrEval for your athletic patients. For this presentation, we will review some foundational principles of the NutrEval profile, discuss common patterns of vitamin and macronutrient deficiencies for the athletic patient, and even integrate some genomic findings into our discussion. So it's very important to establish that the athlete's nutrition needs are just different. Most people need between 1,500 to 2,000 calories a day, but your demand based on the athletic activity can increase by 500 to 1,000 additional calories. The average macronutrient ratio for a non-athlete American is about 45 to 65% carbohydrates, 20 to 35% fats, and 10 to 35% proteins. But for the athletic client, the ratio percentage is going to actually vary depending on the activity type. So if they are in a performance season versus a rest season, what are the body goals for that individual? So if the client is training several hours daily, 4 to 5 days per week, high volume, high intensity training for an upcoming competition, using a higher protein percentage to support quicker and more efficient recovery and protection from injuries, a lower fat percentage to support a leaner physique, and a higher carbohydrate percentage to help maintain liver and glycogen fuel storage will help prepare the athlete for that competition. Aside from calories and macronutrient ratios, we should also keep into consideration meal and snack timing, hydration, plus vitamins and minerals. Tailoring all these considerations to an athlete's body composition, the amount of time spent training, and the type of sport they do can help to improve their performance. So when you start with the assessment of your athletic client, just as with any other patient, always start off with basic blood work and a detailed history of health. For many athletes and coaches, performance goals usually is the top priority, but it will only be achieved if we have a complete picture of the patient. Ask very specific performance questions like timing of meals and snacks, hydration, frequency, type, injury history, recovery timeline, supplements, on and off season dates and workouts, menstrual cycle irregularities for females, recovery time between workouts, muscle cramps, bowel movement frequency, type of training activities, whether it's endurance versus high intensity. All of this is critical because we're looking to optimize performance, not just achieve and maintain health. Many of these clients have tried various diets and supplements to no avail because their information is coming from non-medically trained coaches, trainers, or even Google Doctor. But when you combine detailed medical and performance history with a good nutrition assessment and proper training, your athletic client will notice performance improvements. As a prior Division II field and relay athlete, the focus for many of us was really low weight goals. So I consumed carbohydrate-rich foods simply for energy, but I was very deficient in calories, fats, proteins. And when asked by a doctor, I usually wasn't very forthcoming about the processed foods, the snacks, the caffeine I was consuming. Oh, yeah, and the lack of water I was drinking and the use of enemas due to severe constipation. So all of those things definitely contributed to the several injuries that I experienced, but also it can explain why performance-wise, I just hit a really big plateau. So I encourage you as clinicians to ask very detailed questions and get a minimum of a week's diet diary, hydration, sleep, along with workout schedules, symptoms. After I finally linked my diet, not my weight, to performance, I was able to achieve personal records or PRs during not only practice, but competitions, and I also received many awards. I wish I had a healthcare practitioner like you on my team. But many professional athletes and other individuals who rely on their physical performance for occupation, your weekend warriors, many of them use nutrition assessment to optimize performance. So this isn't something that's new. Okay, I know you're ready to dive into the NutrEval profile and see how it will benefit your athletic patient, but before we do, there are two important concepts we must discuss. First is baseline versus supplemental efficacy or nutritional assessment. If you want to understand your patient's nutrient need off of supplements, you can have them discontinue them prior to testing. That time frame will depend on the type of supplements. For example, a water-soluble nutrient should be cleared from the body in 3 or so days, while a fat-soluble vitamin or those measured in blood will take longer to clear, like a few weeks. But if you want to know how your patient is doing while on their current regimen and how we can tweak that regimen, then you can have them continue supplementation prior to sample collection. So the next important concept is direct versus functional nutrition assessment. You can assess nutrients directly by measuring them, like a standard vitamin D. However, you can perform a functional assessment, not really indirect, but functional. This is where you examine various biochemical pathways to see if your body's demand for a particular nutrient is being met. It is not taking a measurement and comparing you to someone of like age and gender. It is looking to see if the amount of B12 you get from the food and or supplements is adequate to support methylation, detox, good mood, along with other processes, for example. Here is an example you may be familiar with. Methylmalonyl-CoA converts into succinic acid, important for the mitochondria and ATP production, using an enzyme called MMA mutase or methylmalonyl-CoA mutase. This enzyme in particular requires B12 as a cofactor to assist with this conversion. When you lack B12, the pathway to making succinic acid is slowed, and the other pathway to methylmalonic acid production is upregulated, leading to an accumulation of methylmalonic acid. The idea is if we replenish B12, then this pathway will restore balance. So in this example, a lack of B12 is called a metabolic blockage due to insufficient cofactors. However, there are a few other reasons that can impact an enzyme function, such as exposure to an environmental toxicant, having an inherited enzyme deficit like a SNP, and or even a medication effect. All of these factors ultimately will interfere with an enzyme's function on the NutrEval profile. We are mainly focused on insufficient cofactors, and so when we identify which enzyme is impacted, we can generate patient-specific nutrient recommendations to support your clients. So what exactly are we measuring in a functional assessment? Organic acids, which are carbon-containing compounds with acidic properties. Organic acid measurement, it's not new. In fact, we've been using them to help identify newborn disorders for many years to identify inborn error of metabolism. In the functional medicine arena, we are measuring them, like methylmalonic acid, to see if there are metabolic blockages, which oftentimes are due to a lack of appropriate cofactors, and replacing those cofactors can help restore balance. On the NutrEval profile specifically, we're looking at around 125 different biomarkers, both direct and functional, like organic acids, to help support your client's performance goals. So let's take a quick look at the various sections of the NutrEval report. On the front page, we have the results overview graphics, which provide a quick glance at the severity of the results. At the bottom of the front page, we have the functional imbalance pillars, which we'll discuss in a moment. Page 2 is a nutrient need overview, which displays the synthesis of nutritional need based on all the analytes measured on the test. The next several pages are the interpretation at a glance pages, which gives an overall score for the need for supporting each nutrient. These pages are designed as an aid in patient education around the importance of nutrients and how to better obtain them from the diet. Page 7 is the oxidative stress and mitochondrial dysfunction pathway page, also known as the Krebs cycle. This page helps us to understand the process of cellular energy production and all the nutrient cofactors involved. Page 8 is where we begin listing the individual analytes measured on the test. We start with the organic acids, then we list the oxalate markers and the oxidative stress markers such as glutathione, followed by organic acid pathways graphics to demonstrate the utility of organic acids in assessing nutrition. Page 10 is our amino acid page. Page 11 lists the essential metabolic fatty acid markers, followed by the fatty acid metabolism pathway graphic. And on the last page are the nutrient and toxic elements. So let's dig into each section of the report in more detail as we look at a case study. So this is a case study of a off-season training 23-year-old female soccer athlete interested in improving muscle strength, agility, and quicker recovery, not only in between workouts, but after her most recent muscle strain injury. She has GI concerns of heartburn and gas, constipation, had recent antibiotic usage due to dental work. Standard blood work is within normal limits with a slightly low normal hemoglobin despite iron in her birth control. She has a good diet, was taking a 1-a-day multivitamin, which we decided to hold prior to sample collection to get a baseline assessment. Right off the bat, I do see some nutrient red flags. In particular, I'm concerned with B vitamins. She's using birth control, which typically impacts B9. Also, the recent antibiotics will negatively impact the microbiome, and the microbiome helps us to make nutrients, in particular B vitamins and vitamin K. And then with some of those GI concerns, it could actually be rooted in maldigestion or malabsorption and or dysbiosis. So the front page of the report shows 5 functional categories: oxidative stress, mitochondrial dysfunction, omega imbalance, toxic exposure, and methylation imbalance, plus their functional scores. Green, or a score of 0 to 4, indicates minimal need for support. Yellow, or a score of 5 to 7, indicates moderate need for support. And a score of 8 to 10 indicates high need for support. For this client, she has a high need for antioxidants, a mild need for omega plus methylation support, and a low need for mitochondrial and toxic exposure support. Below the functional scores are the markers that contributes to the functional scores. For example, looking at the oxidative stress pillar, we see elevations in indicators of free radical damage and low levels of antioxidants like glutathione, which is how we arrived at a functional score of an 8 out of 10. So let's look at these functional categories and how imbalance can actually negatively impact performance in particular. So with exercise, we increase the production of free radicals because we're moving food into energy quickly. We're also breathing at a faster rate, which can lead to increased oxidative stress and cellular damage. So this can result in performance decreases and increased muscle fatigue. And to counterbalance this, athletes need to consume more antioxidants. The good news is that with consistent training, the body will not produce as many free radicals. We also need to be mindful of other sources of free radicals, including UV light, air pollution, stress, poor diet, etc., that may also need to be evaluated. The mitochondria delivers ATP or energy, which fuels many things, including your athletic performance. Interestingly enough, exercise causes our bodies to make more mitochondria or increase the volume, and it changes the structure as well as the function of existing ones in ways that can actually enhance your physical stamina. So ensuring adequate vitamins and minerals to support ATP production is essential for mitochondrial health and function. Omega imbalance. Who does not want to recover quicker after an intense exercise? Omega fatty acids have been shown to reduce muscle-induced exercise damage so we can recover quicker and better and have the added benefit of reducing inflammation, delivering more oxygen to your tissues, and even improving your nerve-muscle communication or activation. Toxic exposure. Depending on what the toxin is, it can lead to exercise-induced intolerance. Clients experience fatigue, muscle pain. If it's an inhaled toxin, you may experience shortness of breath. Toxins can increase free radical production, which we just reviewed as a cause for cellular damage and muscle fatigue, also poor energy, and also poor recovery. So if an environmental toxin is identified, it's important to find the source, create a plan to eliminate the source, and ensure appropriate antioxidants as well as support detoxification pathways. Methylation is not restricted to DNA and RNA synthesis or detoxification or immune health. It's also used for creatine production out of arginine, and that is involved in skeletal muscle energy production, important for building muscles. So if we experience methylation imbalance due to insufficient amino acids, minerals, B vitamins, or genetic predisposition, our muscle strength and ability to perform will be directly impacted. So back to the client's profile, the nutrient recommendations on the following pages are intended to support these 5 main categories we just reviewed. You will see recommendations for the following categories: antioxidants, B vitamins, minerals, essential fatty acids, or omega-3 fats, GI support, and lastly, amino acids. For this patient, she has a higher need for antioxidants, which will help to combat the oxidative stress finding on page 1. The B vitamin recommendations will support methylation, and the omega fatty acids will support the omega imbalance pillar. Below that is a GI support section. Whenever I see elevations, I consider following up with a GI stool profile because this just provides me with a clue that I need to investigate further, which makes sense with this patient's GI complaints of gas, heartburn, and constipation. Lastly, amino acids. Based on the measured amounts, we're providing recommendations to get the patient above the bottom 25th percentile. We traditionally will see about 3-4 recommendations, but this client has 6 recommendations, which lets me know that there's potentially digestion absorption issues or her intake is not sufficient to meet the demands of her training. Interpretation at a glance on pages 3 through 6 provides your functional score for that nutrient. Green or score of 0 to 4 indicates minimal need for support. Yellow or score of 5 to 7 indicates moderate need for support, and a score of 8 to 10 indicates high need for support. Also, we provide great information about each nutrient and foods that are rich in that nutrient to help support dietary changes. Page 3, antioxidants. Page 4, B vitamins. Page 5, minerals and essential fatty acids. And lastly, page 6, microbiome and digestive support and functional imbalances. Oxidative stress and mitochondrial dysfunction. So we're looking to convert the macronutrients, your fats, your carbs, your proteins, into ATP or energy through the citric acid cycle or metabolization, and it occurs after digestion absorption. Fats are moved into the mitochondria using the fatty acid carnitine shuttle, represented by the blue sleeve. So if there are problems, then the adipic or subearic acid can be elevated. Under carbohydrates, the pyruvic acid is low normal. We know this from the client's diet, that she's not eating a low carbohydrate diet, so the low levels of pyruvic acid are due to magnesium insufficiency. Around the cycle, the first 3 are low normal, represented with yellow, or low, represented with red. Due to low findings, we need to consider precursors, which are the macronutrients, including the amino acids, because they can actually filter into the cycle at various steps. So oftentimes we see a sluggish cycle with insufficient protein in the diet. As we mentioned earlier, it could be due to insufficient intake for activity level or digestive challenges. For low cis-aconitic acid and low isocitric acid, the prior steps cofactors for the enzymes are both Fe or iron and GSH, which stands for glutathione, representing antioxidants. So if you're low in either or both cofactors, this could actually cause the cycle to not convert effectively, resulting in less ATP production. Also, look to the upper right of each step. You'll see in the red circle heavy metals that may slow down the conversions. Fl stands for fluoride, Hg is for mercury, As is for arsenic, and Sp is for antimony. The rest of the cycle actually looks pretty good. At the bottom of the page, we have low normal glutathione and signs of oxidative stress. Lipid peroxides represents oxidative damage to cell membranes, and AOHDG represents oxidative damage done to DNA. So we can provide antioxidants to the client, but we want to understand, why is there an imbalance leading to oxidative stress? I really like to start off with basic blood work to investigate the oxidative damage, CBC, CMP, thyroid, ANA. If a client has an environmental exposure or chronic illness, this too, as well as intense exercise, will contribute to free radical production. The organic acids are grouped into sections based on body systems or function. Upper left column, malabsorption and dysbiosis can lead to recommendations for digestion absorption or microbiome further evaluation or support. The bottom left, we have cellular energy and mitochondrial markers, what we reviewed on the prior page of the report. It can lead to recommendations for B vitamins, minerals, antioxidants that will support the mitochondria and energy production. The upper right are the vitamin markers, which can lead to B vitamin recommendations. The middle right, we have our neurotransmitter metabolites, may either lead to amino acid or B vitamin recommendations. And lastly, the bottom right is toxin detoxification, which can lead to recommendations for antioxidants, plus identification of a toxic exposure. The malabsorption and dysbiosis markers. So the dysbiosis markers can be elevated due to dietary and supplemental antioxidants. However, the diarabinitol under the yeast fungal dysbiosis markers is a marker for candida presence. Due to this client's GI concerns of gas, heartburn, and constipation, plus recent antibiotic usage, I would start with a probiotic, decrease those foods that feed candida like sugary, yeasted, and molded foods and beverages, plus use a broad-spectrum antimicrobial product containing something like berberine, oregano, garlic, even maybe a little bit of Saccharomyces boulardii to help crowd out the candida. Cellular energy and mitochondrial markers. So this is the citric acid cycle markers that we just reviewed on the prior page. Vitamin markers. These markers are all falling in range, although there are B vitamin recommendations, it's not stemming from these particular pathways. Neurotransmitter metabolites. The chironine markers are from tryptophan. This pathway it makes NAD, or the active form of niacin, which is vitamin B3, and all these markers are within normal limits. The catecholamine markers are also in range, along with the serotonin marker. Toxin and detoxification markers. Pyroglutamic acid is an intermediate in the cycle that produces glutathione, so when it trends on the low side, it can indicate the cycle is moving slowly due to low precursors or building blocks, glutamine, glycine, and cysteine. And we already know that all three of these amino acids are low due to the recommendations on the earlier pages. Continuing the organic acid measured in urine, we have our oxalate markers. There is no known clinical relevance of low glyceric acid. We do know that high glyceric acid accumulation is the result of breakdown of both serine and fructose. So it's possible that low levels of this marker are due to low amino acid status and or low fructose intake from your fruits and veggies. Oxidative stress markers. Glutathione. So we see low normal glutathione levels here in serum due to low precursors, the amino acids, but it can also be due to increased use of this particular antioxidant. CoQ10, although in range, is trending on the lower side. It's fat-soluble nutrient, so if we're not consuming adequate amounts of fat or if we have malabsorption of fats, this level can trend low. There are also several medications like beta blockers, statins, diabetes medications that can also impact CoQ10 status. The right-hand side, we have elevated lipid peroxides, so oxidative damage to cell membranes, and high normal 8-OHDG, oxidative damage to DNA. We discussed earlier that antioxidants can help to mitigate damage from free radicals. However, the root cause for these findings should be investigated. It could be that she's training and exerting her body, but there may be something else also going on that we do not want to miss. Again, looking at basic blood work is a great starting point. The bottom of this page, we see some pathways showing us how, using organic acids, we can arrive at nutrient recommendations. The next portion of the profile are the amino acids. Looking at the essentials derived from the diet and non-essentials produced by the body, we want to see the majority of the amino acids trending around the center of the green zones. For this patient, her results are shifted to the left. So insufficient proteins will make it difficult to recover between workouts and heal from injuries, quench free radicals produced from training, also make it hard to detox and have healthy hormone and mood balance. Oftentimes as athletes, we focus on branched chain amino acids or BCAAs because unlike other amino acids, they are broken down in muscles and thought to impact performance. Although true, the other amino acids are also important for helping you to meet your performance goals. For this client, we can consider using amino acids, but we also want to review the diet to see if we have insufficient intake, and we want to ensure proper digestion and absorption. Intermediary metabolites of amino acids. The first two sections, B vitamin markers and the urea cycle markers, are in range. Actually, the urea cycle markers are trending a little bit on the lower side, which could indicate that the client consumes lower amounts of meat. The glycine and serine metabolites, if you add these two amino acids together, you get choline. And choline has many important functions like making acetylcholine, but it also can be used as a methyl group donor to homocysteine when needed. Although we prefer to use the folate cycle if sarcosine is elevated, like we see here for this client, it could indicate that the folate cycle needs support. This is where the B9 and B12 recommendations we saw on the earlier pages are coming from. We may also want to follow up with a serum homocysteine measurement. We did add genomics to this client's profile, so we'll review that in just a moment. Dietary peptide-related markers derived from animal products. So when low, it can indicate lower intake of meat, but when high, it can suggest digestive issues. The next portion of the profile are the fatty acids. So the left side of the page, omega-3, 9, and saturated fatty acids all look good. We know that she consumes healthy fats from fish, nuts, and oils from her diet, and she also uses seeds in her daily vegetable fruit smoothie. The right-hand side, she is low on omega-6 fatty acids. Please remember that not all of them will lead to inflammation. In fact, DGLA is a precursor to prostaglandins, which is important for cardiovascular health, healthy immune response, and calming inflammation. So we want to encourage DGLA through dietary intake of meat and dairy. And we can also encourage GLA using evening primrose borage or black currant. These precursors can convert into DGLA. Mono and trans fatty acids are in range. Delta-6 desaturase enzyme is trending on the higher side, indicating impairment. This is looking at the omega-6 conversion of linoleic into DGLA. We see in the diagram below that several cofactors, including B vitamin, zinc, and vitamin C, are needed to help make DGLA. Lastly, on the bottom right, we have cardiovascular risk markers. Here, the client is trending low for the omega-6 to 3 ratio and the AA or arachidonic acid to EPA ratio, indicating omega-3 dominance. The omega-3 index is the addition of EPA plus DHA, and a 7, pretty good. If there are cardiovascular risk factors, we will aim for an index of an 8 to a 10. Elemental markers on the left-hand column are nutrient elements. Low trending magnesium and zinc to copper ratio, which should be 1:1 in plasma, is skewed to the copper. So increasing zinc foods or using some as a supplement can help with the balance here. Right side are the toxic elements measured in whole blood, providing insight into the last 90 to 120 days of exposure, and everything is in range. Genetic SNPs add-ons are ApoE, MTHFR, COMT, and TNF-alpha. We provide for each SNP health implications as well as clinical management considerations. Starting off with ApoE, it plays a role in lipid metabolism. The higher the number, the higher risk for elevated total cholesterol, LDL cholesterol, plus lower HDL cholesterol. The lower the number, the cholesterol levels look better, but we tend to see higher triglyceride levels. ApoE 3.3 is the most common finding, only with moderate cholesterol dysregulation risks. MTHFR is the enzyme that converts 5,10-MTHF into 5-MTHF, so the body can use, along with B12, to clear homocysteine. This client is heterozygous for both genotypes 677 and 1298, which can result in downregulation, hence the downward facing arrow, of about 50 to 60%. Clinically, we consider using supportive cofactors for this enzyme, B2, B3, ensuring also that we have adequate B9 and 12. But keeping a close eye on this patient's homocysteine levels is also important. COMT is another methylation enzyme that clears catecholamines such as dopamine, norepinephrine, and epinephrine, but also estrogens. In this case, there is a heterozygous finding, so the enzyme's activity is downregulated genetically and can lead to an accumulation of these catecholamines, resulting in mood disorders or hormonal imbalances. Lastly, TNF-alpha is a pro-inflammatory and oxidative stress signaling molecule. This client is homozygous negative, also called wild type in literature. If there is a SNP, we tend to see higher risk for inflammatory and oxidative stress related conditions like cardiovascular disease, autoimmune, and cancers. To recap, the focus for this client is really to assess her diet and digestion absorption, to better understand the low trending amino acids, but also the need for other nutrients. Oxidative stress, understand why there is free radical damage. The client's CBC and CMP were within normal limits, with the hemoglobin trending slightly low normal, so following up with an iron panel, and she did not have recent thyroid labs, so following up with that as well. For methylation, due to the genetic NTHFR SNP and findings on the NutrEval profile, measure homocysteine so we can understand if she needs additional 5-MTHF, methyl B12, and other methyl group donors as supplements. And lastly, give amino acids until we can adjust the diet and correct any digestive issues she may have. Here are a few of my favorite nutrition resources: the Nutritional Medicine by Dr. Gabby, Linus Pauling Institute Micronutrient Information Center that is accessed online, and the Textbook of Natural Medicine by Dr. Pizzorno. In addition, we have a few great resources you should also check out. Let me just really quickly say there's been several advancements in athletic equipment, techniques, and clothing. However, focusing on nutrition can really help set your athletic patient apart. It can help set apart also their training from other athletes. Taking advantage of micronutrient testing can help us understand nutrient deficiencies, whether it's based on increased athletic performance, poor digestion absorption, and or caused by medications. Again, the difference between milliseconds, centimeters, can sometimes determine placement, salary, endorsements, records, or titles, plus one's longevity within a sport. Well, that's the end of the presentation. I just want to thank you again for tuning in. Have a lovely day.